have a treat, so we're going to actually talk about ortho stuff today, since I know we're on the ID block, so we figured this would be a nice segue into something that's trauma-related and ID-related. So we have Dr. Illical, who's actually, for those of you that haven't seen him yet in the trauma bay or even up in the ICUs or on the floors for that matter, he's one of our orthopedic surgeons who has a background in trauma as well. So he comes to us from Pittsburgh, and he's here, and he's awesome, he's aggressive, he's been doing all sorts of great stuff since he's hit the ground. So we're going to get started. And then we've got Joshua following after
Thanks a lot, Karen. So yeah, my name is Emmanuel Illical, and so I'm Canadian, so don't know, Canada's the country right above you guys. So I've got like a pretty varied background. So I did undergrad at UBC, which is out in Vancouver.
That's how I know
And
you.
then I did med school at U of A in Edmonton.
Yeah.
And then I did residency in Calgary, University of Calgary. Then I did my first fellowship in Ottawa, and that was in adult recon. And I did my second fellowship at Pitt, UPMC. So obviously like huge sports town, Continental Energy Center, PNC Park, Open Zoo, and Heinz Field. So I'm going to talk about the acute management of open fractures. So I have no disclosures for this talk. So obviously the definition is pretty easy. So basically it's a break in the skin and the soft tissues that is basically communicating with the fracture and or its hematoma. So an open fracture can vary, right? So from a little poke hole in this forearm on the ulnar side to a massive degloving injury with massive comminution. So etiology, there's obviously direct mechanisms. So MVCs, firearms, falls from a height. You also have indirect mechanisms, either from torsional injuries, such as sports, or fall from a height. But basically, what you want to know is that the extent of trauma directly relates to the amount of energy given by that trauma. So all fractures, regardless of whether they're open or not, have a certain degree of soft tissue injury. And this is actually really important because everyone kind of focuses on the x-ray and focuses on the bones, but it's a soft tissue injury that actually determines your prognosis. So if you all remember back from your physics, so energy is what's transferred to the soft tissue in the bone, and energy is directly proportional to the mass and the velocity. So obviously for a fall from a curb, you can see all these things here. From a fall from a curb, it's kind of 100 feet per second versus a quote-unquote low-speed motor vehicle only going 20 miles an hour will give 100,000 feet per second energy transferred to that patient. As a result of that energy, you're going to have a certain degree of contamination, especially if the fracture is open. And then there's going to be certain patient characteristics that's also going to determine prognosis, mostly with comorbidities, diabetes, peripheral vascular disease. That's going to determine their healing potential and complication. So the most common causes of open fractures, number one is crush injuries. Number two is actually going to be a fall from a standing height. And then number three are going to be road traffic accidents. Obviously, as most trauma patients are, the male to female ratio is higher in males. The most common bones actually affected are finger phalanges, followed by the tibia, which obviously has a tenuous soft tissue envelope, and then the distal radius. And then what I think kind of want to focus on is polytrauma. So 30% of open fracture patients are going to be in polytrauma patients. So probably the most widely regarded classification in the orthopedic literature is this Gustilo-Anderson classification. That was initially done by Gustilo-Anderson in 1974 and then was revised. So, you probably learned in medical schools, grade 1, 2, and 3, and it was based on size. And this is kind of really a misnomer because when they revised it, it's actually like I was talking about. What it should be is based on energy, contamination, the deep soft tissue damage, and then the energy is basically is a result, or the contamination, deep soft tissue damage, all these other things are a result of the energy. So even though they had kind of described it as less than 1 centimeter is grade 1, greater than 1 centimeter is grade 2 and above, you can have a grade 3 fracture, open fracture that has a 1 centimeter wound. Classic example of that would be a gunshot wound. But basically you want to see whether the mechanism is low or it's high. So low energy mechanisms are going to be more grade 1s, and then higher energy mechanisms are going to be grade 2 and above. But then as a clue, you want to see the deep soft tissue damage, the amount of fracture comminution on the x-ray, plus or minus periosteal stripping, although this is more of an intraoperative finding, And then how we subclassify grade 3 fractures are based on either the local soft tissue coverage or neurovascular injury. So local soft tissue coverage just means that the difference between a 3A and a 3B is that after you've done fixation, debridement, etc., you can't actually close the skin, and they require some kind of soft tissue coverage outside of a skin graft. So we're talking like local soft tissue flaps. And the difference between the 3A and the 3B, what differentiates it between the 3C, is a neurovascular injury that actually requires a repair. So often, bad soft tissue trauma, especially in the leg, the dorsalis pedis might be out, but the leg is still vascularized, and the post-tib is still in, and vascular decides not to repair it. That's not a 3C, it'd probably be a 3B. What Gustilo-Anderson found is that the Gustilo-Anderson classification is prognostic only from an infection rate. And that makes sense because obviously the energy to take a grade 3 fracture is going to be significantly higher. You're going to have a higher degree of soft tissue damage, a higher degree of periosteal stripping, which leads to a higher infection rate. In addition to this, the amputation rate is also probably predictive, with grade 3Cs having a 40 to 50% amputation rate. So then I guess what I also wanted to focus on is the initial evaluation in the emergency department. So, I can't stress this enough, and since I've been here, I think things have improved and things, but ATLS protocol is mandatory. A lot of these patients will come in, even from a fall from a standing height, which, a lot of people may think is a low mechanism of injury, and they may have some severe deformed injury, or they've got an open injury. The key is not to be distracted by the presence of an open fracture or an open wound. Obviously, you want to go through your primary survey, so airway, breathing, circulation. Those are most pertinent because they're going to save the patient's life. And, obviously, even in ortho, it's like life before limb. However, in your primary survey, during circulation, there's a lot of orthopedic injuries that can be a major source of blood loss. So pretty easy ones that can be picked up right away are open book pelvis fractures, obvious long bone fractures, especially of the femur and the tibia. And then in addition to that, open fractures can contribute to this blood loss. So obviously reducing or splinting these fractures can help with the control of the circulation and the blood loss. So the other thing that I really want to stress is obviously, hopefully everyone here is going to do ATLS or has done ATLS. Your imaging studies are the 3 imaging studies that are part of the primary survey: your chest X-ray, your AP pelvis, and your C-spine. And so obviously your chest X-ray and your AP pelvis can give you a lot of different information very quickly right away. Patient has an open book pelvis fracture, that can be very easily identified on AP pelvis versus a physical exam, especially by someone who may or may not be experiencing it, and or if the patient has other fractures. Then the other imaging studies that are part of the secondary survey that can assess for fractures and open fractures are going to be your ancillary studies, so an AP and lateral of the entire bone that's affected. Ideally, we always try to include a joint above and below, and ideally in a nice trauma situation when you have a good trauma team leader kind of directing everything, these can be done in the trauma bay with help and people holding the film cassettes, etc. So again, like I said, knowing the mechanism is actually very essential, because number one, you can understand the amount of energy transferred to the patient, and then you can also understand whether the extent of what contamination they were when they suffered the injury. So obviously barnyard injuries, marine injuries, you want to be aware of these because they're going to change your antibiotic protocol for treating these open fractures. So obviously have a high index of suspicion for an open fracture, especially when we talked about things before, polytrauma, etc. So obviously in the secondary survey, a systematic inspection of each extremity is critical. And for that, the E part is exposure. So, cutting off the pants, cutting off the legs, putting warm blankets on them, but actually inspecting and going through a systematic examination of all the upper and lower extremities, looking for deformities, crepitus, and obviously open wounds. Because a lot of small, or quote-unquote small open fractures are often missed, obviously when the patient has larger injuries or more distracting injuries. When you do find a small open wound, it's important to note the size, the location, and the degree of contamination of those wounds. So obviously some of them are going to be very obvious, like that picture of that open tibia that I showed at the beginning. Some of them may not be obvious. My biggest thing is that don't close the wound. So there's already soft tissue injury. There's going to be surgical debridement in the OR. From my perspective, it's clean it, cover it, reduce and splint it, but don't close it. And some EDs, depending on how strict they are, pictures are often helpful, especially if your orthopedic surgeon or whoever's going to be taking care of this isn't available to come down right away. So the other important thing that you have to recognize is that you have to have a high index of suspicion for compartment syndrome. So obviously a lot of the higher energy open fracture mechanisms are going to be higher energy, so they're at risk for compartment syndrome even though they're open. So that's counterintuitive. You think the fascia is open, it may never have compartment syndrome, but that's not true. So again, the Gustilo, there's been studies after Gustilo made his classification that the incidence of compartment syndrome is actually directly proportional to the Gustilo grade, with obviously higher grades having a higher incidence. So the other thing that I want to impart is that compartment syndrome is a clinical diagnosis. So it's going to be pain out of proportion to the injury. That's going to be hard on a polytrauma patient. Pain not relieved by analgesia. When you're assessing the compartments, they're going to be quote-unquote full or tight. In the orthopedic literature, although this may or may not be true now, but I still teach this to all my residents, that pain to passive stretch is the most sensitive finding prior to the onset of ischemia. So once the compartment syndrome is kind of developed and you start getting ischemia within that limb or within those compartments, then the patient will start complaining of hypothesias or paresthesias first, because nerves are more sensitive than the muscle or the pressure it needs to actually occlude a vessel where you get pulselessness. So this is what I really want to emphasize, is that paralysis and pulselessness due to compartment syndrome is a very, very late finding, and if that finding is already found, it's probably too late, and the degree of morbidity that patient will have to that limb, including amputation, is going to be quite high. And then when you want to measure compartments, that's going to be in a patient where a clinical diagnosis is difficult. So you're a tended patient, you're an intubated patient, possibly you're a polytrauma patient. So the initial management in the ED, so what I call it is like an irrigation debridement of grossly contaminated wounds. So if you have like a tibia that's sticking out of the bone and there's grass or hay or whatever it's on it, what I do is I just take a liter saline bottle, take an 18-gauge needle, I poke a bunch of holes at the top, and I wash that piece of bone out with a piece of sterile glove. And then all I'm doing, I'm not trying to clean every little piece, I'm just trying to get out gross debris, because once you reduce that fraction, you don't want that debris to get into the wound and to stay there. After that, like I said, apply a sterile dressing, sterile saline dressing. There's no evidence now that fancy type dressings do any better than a nice sterile dressing. And then the other thing is reduce and splint the fracture. So a lot of docs who I talk to out in the periphery and stuff, or even the emerge who haven't reduced a lot of fractures, are very wary and scared of reducing fractures. And when I talk to my junior residents, orthopedics is not hard in the emergency room. You just want to make a bone straight. So if the bone is crooked, just pull on it and make it straight. You're not going to make it anything worse. Nothing is going to happen, especially patients that, their ankle's at 90 degrees, they have no pulse, they've got paresthesias, everyone's freaking out about vascular. You'll be surprised how many times you make a limb straight, how number one, the soft tissues relax, the kink in the artery relaxes, the perfusion returns, patient's pain control becomes better. So obviously don't forget to check the neurovascular status of the extremity before and after the reduction. Again, polytrauma patients may be harder, intubated patients may be harder to do this. And again, don't forget to obtain post-reduction x-rays. Because obviously inadequate reductions either need another reduction or a more urgent trip to the OR. So something that I want to iterate, so as soon as you find an open fracture, you should automatically be thinking tetanus. So this should be immediately initiated in the ED, and ideally in the trauma bay. So as obviously most of you know, there's two forms of prophylaxis, either the toxoid or the immunoglobulin, and it's based on history and the amount of vaccinations that you've had before. So in a polytrauma patient, I think that everyone should at least receive the vaccine, and if you don't know the history, and if it's a grade 2 or 3, so more contamination, more energy contributed, you give the vaccine and the immunoglobulin. The other big thing that I want to really stress is that as soon as you think an open fracture is there, in addition to immediate administration of the tetanus, it should be antibiotics. So in the original Gustilo paper that he published way back in 1974, they actually cultured a lot of these open fracture wounds and found that 70% of them were actually contaminated with bacteria. So we've gone away obviously from culturing wounds because the level 1 and level 2 evidence show that, number one, wound culture probably doesn't predict post-operative infection, and it doesn't really affect your management. But there's multiple level 1 and level 2 studies that show that antibiotics actually prevent infection after long bone fractures. And this can prevent it up to even 50%. So what's even more evident now, I think, in the literature that's becoming evident is that the timing of antibiotic administration is crucial. So obviously, you want to treat this at the time of exposure before the infection develops. So, these authors were kind of pioneers in addition to Gustilo in doing a lot of the early open fracture studies, showed that there was almost a double increase of infection rate if the antibiotics were administered after 3 hours. But, 3 hours I think is too late. As soon as they're rolling in the ED, if there's any indication of open fractures, after IV access and resuscitation, antibiotics should be going in. And it's important, and these authors here said, it's actually emphasizing that the administration of antimicrobial agents is for the treatment of bacterial contamination for traumatized tissues, not necessarily for prophylaxis. Because as soon as you get that big open grade 3 open fracture, it's already contaminated at the scene. So then, I guess the other literature controversy that sometimes, orthopedics has with other ID, ED, etc., is the antibiotic choice. So at this moment, there's multiple level 1 and level 2 studies show that first generation cephalosporins, and the most common form is going to be cefazolin or Ancef, markedly decreases infection rate. So the majority of patients, I think don't have a first generation cephalosporin allergy. If there's a true documented penicillin allergy where they have hives, then some people will advocate clindamycin or vancomycin. So clindamycin I have a problem with because it's bacteriostatic and not bactericidal. So I would prefer vanco in that case. But vanco takes an hour to infuse, etc. And the cross-reactivity with a first-generation cephalosporin and a true penicillin allergy is much, much less than 1%. So I think the majority of the patients, every patient with an open fracture should get Ancef. And there's great evidence for that. So the evidence to increase your antibiotic coverage, specifically in aminoglycoside to cover gram-negatives, was advocated by Gustilo again, because a lot of their wound cultures, especially in grade 2, grade 3s, had gram-negative bacteria. So right now, there's probably not great evidence to actually support it, but I would say most orthopedic surgeons for a grade 3 and above will add an aminoglycoside as long as kidney function is okay and there's no allergies. And if there isn't any problem with the aminoglycoside, we'll substitute for like a third generation cephalosporin, which will cover your Ancef as well as your Gent. The penicillin or the Pen-G is when you have your farmyard, marine, or possible bowel contamination, because you want to cover for anaerobic bacteria. So this is kind of my antibiotic choice summary. So Gustilo grade type 1, 2, 3, everyone gets a first generation cephalosporin, and that's immediately upon presentation to the ER, and then it's every 8 hours redosing because you don't know when that patient's going to go to the OR. Then for personally, the patients who could tolerate it, anything grade 3 and above, I add an aminoglycoside. And so there's multiple kind of studies showing what you add, and I personally use Gent, but I use 5 milligrams per kilogram as a one-time initial bolus, and then I just give it every 24 hours. And there's been some studies that show that that's just as good as dosing it every 8 hours. And then obviously, like I said, farm, marine, bowel contamination, you want to add Pen-G to cover for that anaerobic bacteria. So the other, I guess, big controversy is this antibiotic durations. So at this moment, the optimal duration of an antibiotic course has not been well defined. So the convention when I was going through medical school, when I was going through residency, is that you gave IV antibiotics for 3 days after the open fracture, went through surgical care based on adequate soft tissue coverage. So after it was closed, you just gave them 3 days of IV antibiotics, they got discharged home. However, more recent evidence, kind of looking in that, there's no really good evidence shows that extending the antibiotic coverage beyond 24 hours decreases infection rate. And so when I say beyond 24 hours, beyond either the 24 hours of definitive surgical care or the 24 hours if it's going to be non-operative care. That being said, my bias, again, as I said at the beginning of the lecture, the soft tissue coverage of that bone, of that open fractures, is paramount. So personally, my grade 1 and grade 2 fractures, if I'm taking them to the OR, I'll put them on 24 hours to 72 hours of antibiotics post-op. And that a lot, the 24 to 72 depends on patient factors. So immunocompromised patients, diabetics, etc., I'm a little bit more weary about, and I'll treat them a little longer. All grade 3s I treat for 72 hours. And then grade 3B specifically, I treat until plastics has actually covered them with a flap. And that's because there's been multiple studies now that show that the longer that a grade 3B fracture is left uncovered, the higher the infection. So surgical management, again, is another controversial topic in the orthopedic literature. So obviously surgery for open fractures that need surgery is critical in preventing infection and promoting healing. And that's because you want to debride all the contaminated and non-viable tissue. And so when I say this, and I preach this to my orthopedic residents, because everyone focuses on the bone, the soft tissue coverage or the soft tissue envelope is actually as important, if not more important than the bone. So that means skin, all subcutaneous fat, all the muscle is completely and radically debrided, and this may need more than one procedure. So the optimal timing of initial surgery is being heavily debated as well. So historically, there's been this quote-unquote 6-hour rule, and then that was in Gustilo's original paper. But if you read his paper, what he's basing this on is an 1889 paper on Friedrich, who actually injected like dust into guinea pigs and then found what time they cultured, and he found it was cultured, or they started to grow a lot of bacteria between 6 and 8 hours. And his conclusion was that a surgical debridement between 6 and 8 hours wouldn't adequately take away the bacterial contamination. So all that literature is based on this 1889 paper. So there's now many recent studies that have looked retrospectively and tried to look prospectively, showing that there's no advantage for the 6-hour rule, but the caveat is, number one, it's provided that antibiotic therapy was initiated. Like I said before, delayed surgical wound closure, again, also increases infection. So in that, obviously you have to take literature with a grain of salt, and you have to take literature and make your own kind of conclusions. So my personal bias is that if you had an open fracture, your family member had an open fracture, I want to take all open fractures that require surgery within the fastest time possible, given the resources available. So, when I was at UPMC, we could open an OR whenever we wanted. So grade 1s got taken in the middle of the night, anything got taken in the middle of the night. It's different, so I've worked in multiple centers, whether they're level 2, level 1, and your OR resources sometimes aren't available to do that. So grade 1 and 2s that you can do an adequate debridement or irrigation debridement in the emergency department, you administer antibiotics, you splint them, you can take the patient to the OR in a controlled manner the next day, when you have a fresh OR team, when you have a fresh anesthesia team. I think that's completely reasonable, and the literature completely supports that. What gets a little less clear is the grade 3s. So I think grade 3s, I personally take them within the quote-unquote 6 hours, or, like I said, as fast as I can. Obviously, grade 3Cs are different because it's a vascular point of view, and the vascular, the warm perfusion rate is 6 to 8 hours, and so those patients I take urgently, stabilize the fracture, at least only temporarily, so the vascular surgeon can do their work. So I guess the other, I kind of mentioned a caveat is like gunshot wounds. So there's a lot of literature now showing, low velocity gunshot wounds can be treated non-operatively with IV antibiotics or PO antibiotics versus intermediate and high velocity. So so low velocity specifically in orthopedic literature and ballistic, literature is less than 350 meters per second or less than 2,000 feet per second. So those, as you know, most of the ones at Kings County, except for magnums, most of these are going to be quote-unquote low velocity gunshot wounds. However, a low velocity gunshot wound doesn't necessarily mean you're going to have a grade 1 or grade 2 fracture. They're usually comparable, but it also depends on the distance they were actually shot at, etc. And so you have to take into account the actual fracture, the fracture comminution, and the actual x-ray, rather than the little poke hole in and out that you see actually on the patient. Obviously, when you get to more intermediate velocity and high velocity gunshots, the actual soft tissue injury is going to be more extent, especially the exit injury, because the degree of energy dissipated within the soft tissues, and the bone is going to be higher with intermediate and high velocity. And so the management of gunshot wounds, I think, is kind of like I kind of follow this. So if it's a gunshot wound that goes through the soft tissue, there's no bony involvement, then these can be local wound care and likely no need for prolonged antibiotic coverage, and definitely don't close these wounds. So I let them all close by secondary intent. So if it's going to be a non-operative fracture, so let's say a low velocity gunshot wound, there's a minimally displaced midshaft ulna, forearm stable, that can be washed out in the ER. I personally give them a dose of obviously IV antibiotics. Depending on their patient factors, I'll either admit them for 24 hours for IV antibiotics and then discharge them home, or send them home on oral antibiotics, even though there's kind of no evidence for that. But if it's a fracture that actually requires surgery, so that's based on fractures, like lots of different factors, so fracture stability, patient stability, whether it went in the joint, etc., then that's when I take them to the OR and treat them exactly like open fractures that we've discussed. So, I guess my take-home points are: number one, like I said, don't be distracted by a big open fracture. Always follow ATLS when evaluating a trauma patient. Carefully examine any patient for an open fracture. When you identify that open fracture, you want to give immediate administration of antibiotics and tetanus. And all open fractures, at the very least, I think, should get a first-generation cephalosporin. Those open fractures, especially if they're big and open, just do a simple irrigation, sterile dressing, and then reduce and splint the extremity. Thank you. Any questions?
Okay.